World Bank. Okay, all right. So thanks for being here today. Really, what we'd like to talk about as the theme for the summit is really how we can achieve primary health care on the journey to achieving universal health coverage. We know that the population of Tanzania in the recent census has shown us a significantly increasing young population. We'd like to talk about some of those population dynamics in the setting of UHC. Given that, maybe I can begin with Melissa, if that's okay, just to have a good understanding of what's happened since the population and housing census of 2022, to really understand what strides UNFPA is taking with the government of Tanzania as a partner to ensure a healthy, educated, and young, thriving population. Maybe we can begin with that.
Thank you very much. Good morning. Thank you for having me. It's a pleasure to be here with you this morning to discuss the issue of population dynamics and the implications for health, and in particular, universal health coverage. To pick up on the question that Dr. just asked, one of the reasons why we look at the issue of population dynamics is because it talks about the ways in which populations change over time, right? So we're talking about things like population growth, things about age structure, population composition, and the geographical distribution. And we know that those elements are important because they have implications for planning, they have implications for policy making, and ultimately in terms of the country's economy, right? In the context of Tanzania, the immediate factors that we will look at today are around fertility, mortality, and migration, but specifically on the issue of fertility as a key factor for changes in population structure. In the context of Tanzania, as you know, there is a high fertility rate, right? And while it has declined over the years, currently we have 4.8 children per woman, and it goes as high as 5.5 children per woman in rural areas. So Tanzania has a high fertility rate. And one of the consequences of that high fertility rate is that the population grows at a relatively rapid pace. So in the context of Tanzania, the population growth grows at a rate of 3.2% annually, which is more than twice the global average. As the doctor just said, in the recent population and housing census, the population of Tanzania is now placed at 61.7 million. And at the current pace of growth, I just mentioned that it grows at 3.2% annually. What it means is that the population of Tanzania is expected to double in 22 years. And in fact, there are 8 countries in the world that are expected to be responsible for more than half of the increase in the global population by 2050. Tanzania is one of those 8 countries. Now, we talked about the high fertility rate, we talk about the rapid population growth, but for UNFPA, one of the most significant features of the Tanzanian population is the fact that there is such a significant youth population, an adolescent and youth population. So what we know is that over 60% of the population is comprised of young people below the age of 24 years old. And therefore, what it means is that with this large youthful population, there is the possibility of achieving what we call a demographic dividend, which is that window of opportunity for economic growth that the country can attain, but only if the investments are made in the health, education, governance, and the economy. So therefore, the point is that with this large population, Tanzania stands to gain significantly in terms of the country's development aspirations, but only if the right investments are made in this adolescent and youth population. Now, the National Development Plan, both for mainland and Zanzibar, both recognize the importance of ensuring that adolescents and young people are healthy, that they are educated, and that they are skilled to take on jobs that are created in the economy. And Vision 2025 as well underscores the importance of investing in the country's human capital resources so that we can harness the demographic dividend. So within the context of Tanzania, as we talked about this large youth population, we talk about the rapid population growth, we talk about the young people and the possibility of young people contributing to Tanzania's development. And therefore, within the context of this conference and the discussions that we're having today, what is the implication in terms of the health sector? Now, we know as well that health is recognized as a key driver of economic development. Healthy people generally are more productive, they have higher average incomes, they spend less on health care, and create savings that are an important source of economic investment. Because of the importance of investing in health, right, and that is key for human capital development and economic development, it is key to invest in health and in particular, universal health coverage. From UNFPA's point of view, we work quite a bit with countries, including with Tanzania, to connect the dots between the importance of population dynamics, and especially those elements I just outlined, fertility, mortality, population growth. But we make the link between population dynamics, reproductive health, human rights, and sustainable development, because they're all connected. And depending on how a country manages those population dynamics, it can therefore determine the country's development trajectory. Now, the evidence also shows us that in order to achieve the Sustainable Development Goals, which we're all aiming to achieve by 2030, the targets for universal health coverage, particularly around reducing maternal mortality, in order for countries to achieve that goal, they must prioritize the core package of sexual and reproductive health services and essential supplies. So sexual and reproductive health, for example, helps in the prevention of teenage pregnancies, in the prevention of HIV infections, right? And so these are elements that when we talk about young people, if we look at teenage pregnancies, about 30% of young people drop out of school due to teenage pregnancy. What that means, or adolescent girls, that if they don't continue in that education, it has implications for their ability to earn in the future generally, and it usually impacts their ability to contribute productively to the economy. So sexual and reproductive health as a part of that health package is absolutely critical, and ensuring access to and utilization of quality sexual and reproductive health services, particularly for adolescents and young people, essential to achieving universal health coverage. When sexual and reproductive health needs are not met, particularly for young people, then it compromises their ability to transition successfully to adolescence and adulthood. So within that context and that picture that I'm outlining now, with this large population in Tanzania, this large youthful population, what actions do we need to take to ensure that these people are equipped to meaningfully contribute to the development of the country, and what is the role of the health sector in ensuring that Tanzania realizes its human capital? And you will recall in July, there was the Africa Human Capital Health Summit right here in this very convention center. And Her Excellency, Honorable President Dr. Samia Suluhu Hassan said it, that there is no better time to deliberate on the human capital issue than now. She said we must set clear priorities in family planning and sexual and reproductive health education among the young people. End of quote. So universal health coverage for all ages cannot be achieved without reaching this large adolescent and youth population. In order, therefore, for us to transform and to make significant progress where UHC is concerned, we have to transform how health systems respond to the health needs of the population, but particularly the health needs of this large population of adolescents and youth. Because we know that health services play an important role in reducing preventable poor health outcomes and in supporting young people, as I mentioned, to transition into healthy adulthood. So in closing, in terms of the key messages that I would want us to take away from this brief overview, it's one, the importance of population dynamics, including population growth, including fertility rates, and in the context of Tanzania, how that has shaped this large youthful population. And therefore, the message is, if we are to effectively uphold the human right to quality health services, including sexual and reproductive health, adolescents and young people must be central in the discussion around universal health coverage, particularly those adolescents and young people who are most vulnerable. We need to also place emphasis on poor, those who are poor and in communities where population growth and fertility is very high, and therefore we need to look at, in terms of UHC and SRHR coverage, we need to look at what are the groups that are most in need, what essential services do they need to receive, and what provisions can we use to prevent financial hardship due to healthcare costs. And finally, what it means for us within the context of this population dynamic and this feature of this large youthful population is that policymakers and the health system in general must adapt to this demographic, right? And migration patterns. I haven't touched on migration because we don't have the time, but we also know that migration and urbanization is significant in the context of Tanzania. Dar es Salaam is slotted to be a mega city by 2050, meaning that it will have more than 10 million people. What does that mean in terms of how we plan for healthcare for this 10 million, which will include significant young people? And so those are some of the elements that we need to consider. The fact that at the center of ensuring that UHC remains accessible, equitable, and sustainable, we must ensure that we're investing in the health, well-being, education, and skills of our young people in particular in order to contribute to Tanzania's development aspirations. Thank you.
Thank you very much. You've said a lot of very inspiring comments that we are reflecting on. Before I move to Professor, I just have a couple of questions to follow on to what you've said. An incredible statistic, really, that more than 60% of the population is less than the age of 24. Curious your thoughts on how to integrate some of the family planning packages you've spoken about that Mama Samia addressed during the human capital development engagement earlier. And what does it mean in terms of realizing UHC to be sure that where we are providing primary healthcare services, we are offering integrated packages? Can you comment a little bit on that?
Thank you. And I think that actually speaks to, I was watching the time, but certainly in terms of the work that UNFPA is doing here in collaboration with the government and people of Tanzania is working with the health sector in particular to ensure that healthcare providers are equipped with the information, the knowledge, the services, and the supplies to deliver healthcare services to young people, including family planning. But in Tanzania and in countries, there are challenges and barriers that young people do face in terms of accessing these services, but we're happy to see progress has been made. And so what we do is we work very closely with the health sector, with the education sector as well, through looking at comprehensive life skills education for young people that allows them to equip them to make decisions around accessing services. But it's an integrated approach, it's a multi-sectoral approach, working with the healthcare providers, with the education sector, with the protection sector, because also the issue of gender is critical. Because one of the things I didn't mention, but in terms of adolescent pregnancy, there's also a link with child marriage, which we have high levels. So in terms of an integrated approach, it works with multiple sectors to ensure that family planning information, services, and also supplies are available so that the population can access these supplies and these services. We also work at the policy level to ensure that there is an enabling policy environment that will allow young people to access this information and these services. And so, between that enabling environment at policy level, in terms of supplies, to ensure that the services are available. And the other key element is that demand generation. So working with young people themselves to ensure that they are equipped and that they have the autonomy to access those services, which can help them to prevent, as I mentioned, early pregnancies, sexual and reproductive health, ill outcomes. And therefore, we emphasize the importance of ensuring that those sexual and reproductive health services are a part of universal health coverage and that package of services that will empower young people and that will help them to transition successfully into adulthood.
Thank you very much. I think we'll come back to you again, but now we'll move on to Professor. As we talk about population dynamics and the rapidly growing population, urbanization as well, we know that lifestyle choices have also changed. We know that we're seeing an increasing number of non-communicable diseases. this sits on the, on the foundation of more typical infectious diseases that Tanzania has seen. And many people refer to these NCDs that are upcoming as a new epidemic. So when you think about this growing population, this significant population, you said by 2050 of 10 million just in a mega city of Dar es Salaam, what does that mean, Professor, in terms of our understanding and awareness of non-communicable diseases? And what do we need to do to ensure that we achieve universal health coverage, not just from mitigating infectious diseases, but ensuring the right response to non-communicable diseases?
Thank you so much for your very interesting question. This is a challenging topic, and in tackling non-communicable diseases and the double burden. I call it double burden because you have communicable and non-communicable diseases. We must prioritize prevention, education, and accessible health care for all. Universal coverage, as my colleague was talking about, especially considering that 80% of 36 million deaths globally, and 98% of HIV deaths globally are happening in the developing country. So it's a huge problem that need attention. In early 2000, the NCD in terms of burden using DALI were ranked, and they were ranked low in early 2000. But it is projected that by 2030, they will be ranking top. Already, they are top. Things like depression, cardiovascular diseases, hypertension, injuries, and diabetes, they're becoming a major problem in our society. So, and our health system is well equipped with communicable diseases. We are very good. I was talking earlier today, if you ask me about how many people living with HIV and AIDS, how many TB, I give you a figure right away. But ask me about diabetes, hypertension, it's an issue. And it is the one that is killing people now, you see? In developing countries, let's talk a bit about a few of them, like hypertension. In developing country, hypertension, the prevalence of hypertension varies. It's about 30%. It varies from country to country. It's about 30%. In most countries in Africa, now it's more than 30. Some have even 50%. So you can see that this is a really big issue. Let's talk about diabetes a bit. First, we noted progress which was made by HIV program, which now they have reduced mortality. The mortality in Africa is like 500,000. And more than 65 are accessing treatment, everything at the facility. In contrast, when you talk about diabetes and hypertension and the others, I'm using diabetes and hypertension. It's very common, but again, diabetes and hypertension is risky for cardiovascular and the other communicable diseases as well. More than 100 million in Africa, right? And those who are accessing service varies, of course, from country to country, 5 to 20%. Think about it. And only less than 10% are controlled if you talk about diabetes and hypertension. So I think this is a huge thing that we really need to rethink. Let's come to East Africa. With limited data and research, we have figures that they are contributing up to 30% to 40% of all mortality, of all deaths that are happening in East Africa. When you look at the trend for like 30 years, from 2000 to 2030, we see the increasing trend for the NCDs and the decreasing trend for communicable diseases, including HIV and TB and malaria as well. So you can see the picture is changing, but we are still with very strong health system for communicable diseases. Let's discuss a little bit about the burden of a few of them, like cancer in Tanzania. I took it from the National Cancer Control Strategy, that cancer ranked fifth in causes of death for adult men, and second for adult women. Leading cancer are cervical, Kaposi's sarcoma, and prostate. So we have issues that we need to focus on. The STEP survey, which is a national representation, this was done, they are repeating another one now, but it shows the alarming prevalence of risk factor for NCDs. 26% of Tanzanians had raised blood pressure, 11% impaired fasting glycemia, 9% raised fasting blood glucose, with, of course, a little bit variation between male and female. But we know with NCD, the good news with NCD is that 80% of the 4 major NCDs can be prevented by lifestyle. 40% of cancer can be prevented by lifestyle. And therefore, we have like 4 main risk factors that are contributing to increase in NCDs. Physical inactivity, harmful alcohol consumption, unhealthy diet, tobacco use, and these are escalated by the transitions, 3 transitions, epidemiological, demographic. You are talking about demographic and nutritional transitions. So those are the things that we need to focus in order to change the situation. Coming to the traditional risk factors for NCD, as I said, the survey, which is a national representation, the percentages are alarming for the risk, but notably, only about 3% of Tanzanians eat recommended servings of fruits and vegetables. This is a big thing. The other noted issue is high birth of prevalence of sickle cell, which is also another problem that is coming. But with this, you see, the NCD comes with things we call comorbidity or multimorbidity. You see, comorbidity and multimorbidity refer to having multiple conditions in one person. This is also coming up as a problem. And we know with this, the risk of death is very high, hospitalization, high health care utilization cost, reduced quality of life, and treatment complications. So you can see that NCD, they are coming, and we are not prepared. I would like to discuss a bit now the issue of like double burden or comorbidity, taking it from HIV. You see, with HIV, there's factors that are associated with comorbidities. And these are related, they are HIV-related factors, like HIV infection, you get inflammatory markers that are associated with increasing incidence of NCD. But also they are exposed to the traditional risk factors as well. ARV, they have increased their life expectancy, so they live longer, they are exposed to NCDs. And therefore, NCD, you see it killing people living with HIV more than we expected with other opportunistic infection like TB, crypto. I'm coming from TB, I'm an HIV person, but in the last 10 years, I saw that I needed to widen my portfolio into NCDs. And there are frequent cardiovascular risk factors in HIV, including hypertension, lipid profiles, and other risk factors. It's very common. And also the comorbidity or multimorbidity, having 1 or 3 conditions in one person, increases with age. But it is more in HIV than in HIV negative counterpart. So you can see the problem that we are going to face. There are surely data from PEFA, from African countries like Mozambique, Namibia, Nigeria, Rwanda, Tanzania, Uganda, Zambia, showing life expectancy of people living with HIV that has increased equal even to the normal population. Cancer related with HIV, we know them: cervical cancer, anal, liver, Kaposi sarcoma, non-Hodgkin lymphoma, and yet we know there are vaccines like hepatitis B virus vaccine, human papilloma virus vaccine. Some country government has included into their programs. And this intervention, if they are really implemented effectively, they can help us deal with that. Cervical cancer gained significant attention in Africa, and therefore countries are trying to tackle cervical cancer by vaccination and things like that. There are means for screening. If you screen them early, they can be treated, things like that. But you need an effective system that you can detect and respond immediately. HIV infection and medication damage kidneys, right? The issue of double burden. And about 30% of people living with HIV, they're having this renal issue, renal insufficiency, and this calls for urgency for public health action in this area. In terms of the double burden, just TB also is not unique. Notably high, you see high angina, mental health disorder, diabetes, and hearing disorder in TB. And the risk of having a comorbidity in TB increase as you have like more than 3 conditions in one person. So we have a problem. Through our study, we conducted a study here. We are developing integration model in Tanzania and in Uganda. And we focused only on hypertension, diabetes, HIV infection. The multimorbidity or comorbidity was about 20%. So what's the way forward? There are a lot of documents earlier on in morning session they were talking. There are a lot of documents in shelves at the global level, at the regional and at the national. There are frameworks, action frameworks already. If they are used properly, we can be able to control this. And this document they have, because they originate from WHO, country have also developed this document. And I feel that this WHO tool should enhance surveillance, prevention, implementing best buys in prevention, but also strengthening healthcare services, focusing on primary healthcare system. World Health Assembly endorsed the integration prevention framework because, you know, we have a lot of vertical programs. And this has also, this document exists at the policy level, at the government. But what is lacking is action because of capacity, resources, and the limited investment in research, how to do this kind of integration. We conducted a large cluster randomized trial in Tanzania and Uganda, and we were offering a one-roof service for HIV, diabetes, and hypertension. We enrolled about 7,000 participants, and we noted that after 12 months, the retention was very high, more than 90%. The viral suppression was very high. It means there were no adverse effect on HIV system. And this paper, within 3 weeks, is coming from the Lancet, main Lancet, will be published, and many people will read it. So I believe integration can offer solution to this. Other countries that are working with integration include Malawi, Kenya, South Africa, Swaziland, and they are particularly focusing on cervical cancer, diabetes, and hypertension, but scale up to the national level is another challenge because of resources, because of capacity. And we need to focus to see how we can do this. Now, how should we manage these comorbidity or double morbidity things? I believe the model must take care primary health care investment together with health systems to have a comprehensive continuum of care with integrated package of health promotion and services. You are talking about family planning and other things. They can be integrated. What you need is the capacity. Capacity to carry out such an integration model in a very effective way. So effective NCD prevention should include comprehensive strategy across patient pathway. Primary health care plays a central role in integration of health promotion and service, and vital component of primary health care should include advocacy, political commitment should be there, equity, access to care, effective surveillance. And I would like to end by emphasizing that it is essential to strategize policy and mobilize resources to strike the balance between primary and secondary prevention when we deal with this double burden, and focusing on common risk factors for infection and non-communicable. Thank you very much.
Thank you very much, Prof. Thank you. You mentioned a few things, and it's a nice transition to our colleague that's joining us from the World Bank. Just as a quick overview, we've talked about the changing population dynamics in Tanzania, the growing population, the significant youth bulge that we're seeing. In addition, we've discussed issues around this silent killer of NCDs, the burden that's now being placed even on the communicable diseases that we're familiar with, like HIV or malaria that's endemic, and how we must actually pay attention to those preventable diseases through health promotion and outreach and surveillance, as you've mentioned. You did talk about investment and what is the need for capital investment, both financial risk investment from an individual level as well as government's efforts. So I'd like to introduce our third panelist, Mariam Ali from the World Bank. You can give us a quick overview of your work to date, but I think it's a nice transition to think about what does all of this now mean in terms of financing, in terms of how ensuring an appropriate path from primary health care to universal health coverage, what's really needed from an individual perspective as well as from a government perspective to support resilient and sustainable health financing.
Thank you so much. Good morning. Apologies for coming a little bit late. My colleague who was supposed to deliver this note is sick, Anissa, so I volunteered. And this is the cost, coming late, sorry. But better late than never. Yeah. I decided to come because I thought this is a very important topic to discuss. And when I read the snapshot which organizers shared with us, I thought it's not going to be complete, this discussion, if we will not show up. So, as she has rightly said, it's really complementing to what I've just heard, but I believe even from the other speaker. I remember when I joined Ministry of Health 20 years ago, my colleagues, my health economics colleagues in the ministry, they were talking about financing, health financing. It's like blood in the body, in the human body. How important it is, it's like blood. All other systems cannot work without that blood to flow smoothly, yeah? You can have blood, but if it doesn't flow, so there are many other areas where we are supposed, not other, all areas concerning health financing need to be discussed, need to be flexible, need to change, we need to be innovative. When I say health financing areas, it includes resource mobilization, it includes how we pool resources, it includes how we pay for these services. Now, most of the low-income countries, actually, we were asked to discuss about low-income countries, but I also share some experiences in some few countries I know. We've most of the time focus on one area, We sometimes, before 90s, we are focusing on only resource mobilization, how to get more funds. If you remember, and if you don't remember, let me remind you, we started with user fees, only user fees. But we didn't really think through how would user fees impact service delivery in the system. After some years, we introduced CHF, together with the NHIF. Then we did a lot of other reforms, but lucky enough, we are growing as government, we are growing as individuals. At some point, government decided to do comprehensive health financing strategy, which looks at a health financing spectrum from mobilization to financing. So that's what I'm going to do. Now, what I would like to flag out are just a few challenges of health financing, given that all countries, they aspire to move towards universal health coverage, but at the same time, we have a number of things. But at this point, we're going to discuss about population dynamics. We have urbanization. We have everything you can talk about, which influence whatever we are doing. Now, with population dynamics is, sorry, my yeah, okay. My colleague who just ended, we have emerging diseases. Age structure is changing. We live longer. We have a bulging youth population. What does it mean to the health system? It means more resources. It means sustainable resources. Now, the most chronic challenge is weak fiscal space. All low and middle income countries, we have weak fiscal space. What do I mean? We have little money. Governments have little money, just like us individuals in their countries, because we are the ones who are paying taxes. So when you don't have money in the country, it means you are not going to allocate enough resources to the health system. Health care is a luxury good in economics. The more you have money, the more you spend on health care. So low-income countries, we have weak fiscal space. It means we are allocating little resources. Now, we have these new double burden diseases, chronic diseases, new technologies. It means cost is going up. Even if there are no, we don't have population growth, just these dynamics push and really introduce a lot of forces and frustration in the system. It means we need more money. We have youth now. I remember when I was studying, I think most of us, in our stream, we were only 20 students, now 80. It means you need 80 package of youth with friendly services. You get it? How flexible is your financing in the system is? Very inelastic, not that much flexible. So that is one challenge. The second one, I've implied it, high cost. We have new technologies. They are very good, but they are costly. It means more resources are required to the sector. People are now educated enough. More people are more educated. They know what they want. They know what they need. So they also introduce a lot of pressure in the system. Because before you go, a doctor tells you what you're supposed to get, but now I say, no, I'll go to a private doctor, I'll go to another hospital and discuss with the doctor. Maybe I need this, I don't want ultrasound after every other month. For my pregnant woman, I want every month. That's how it happens. And those are the things involuntarily bringing pressure in the system. We also have unequal distribution. Those are the challenges, financing challenges, unequal distribution of resources. And surprisingly, it's a chronic disease to all low and middle income countries. Our urban areas have more, they get more resources. Why? We allocated them more human resources. Most of us, we want to stay in Dar es Salaam, we don't know how that impacts the system. It means per capita in those regions is higher than Rungwe, than than Songwe or Katavi. Per capita. It means those people in Songwe, they receive less quality services because one nurse covers 1 million population. That's just an example. Ministers of Health don't take it very seriously. Just an example. But the proportion is obviously, it's not equal. So that is also because our countries, they focus on equitable allocation of resources. We want to serve more poor people who need the services most. Other challenges, I have many, but I would just like to talk about few. We have experienced, what happened, doctor, in Bukoba, Marburg. In my growing, I didn't hear anything like that. So those are the things. You can't believe how much went to Marburg. Where did we get it? It means we took that money from somewhere else. Is it in the health system? Those are the things which stress. Those are the challenges. Now, those are just few. I have several. Just because of time, let me end there. Those are the shocks. Those are the challenges we are facing. Now, how do we deal with these challenges? There are many ways. You can use financing models. They try. They don't solve the problem 100%. Some countries, they decide to take one model. Some, they do a hybrid. Some countries like UK, they have taken taxation, government tax, only government tax, 100%. But what does it mean? Your salary goes maybe 40%. Yeah? Sometimes we praise them, but we don't know the cost. But other countries like Germany, and maybe most of the low-income countries, we have decided to follow Bismarck model. A hybrid, which includes Bismarck model, insurance schemes, and government tax. Now, those are the financing models. When you go for taxation, no problem, 100%, because most of our taxes are already equitable. The more you pay, you earn, the more you pay. So it means those who pay less, who earn less, they pay less, they contribute less, they carry burden less. Yeah? I don't know if I'm, yeah. So that's the best, but that is impossible because of the fiscal weakness which we have. Now with insurance, again, we have a challenge. Most of the low and middle income countries, they have a bulging population of informal sector. Saluni, they get a lot of money, but how do you get them to contribute to the health insurance? Boda, how do you get them? So we always come with the hybrid. Hybrid helps government to finance the poor who cannot pay 100% and to catch formal sector which can pay, and we have a way to catch them. We can just go there direct to our payroll. Easily, one button, 3% off. But how do we get this? This we call them missing needle. This is the headache of all countries. In Tanzania, you have had that bill which went to the parliament last year. It has been dragging. Last week, actually not last week, it was Monday. I was attending a meeting, Nairobi. They're also struggling, introducing social health insurance. The struggle is the missing needle. How do we catch those people? How do we save them? But also, how do we use them to save others? Because we believe in cross-subsidization. Those saloon people, boda, they're not sick, but they can contribute, and our old people who don't work now can benefit. And after 50 years, you boda, you'll also benefit from other bodas. You get it? But now, how do you do it? That is a challenge. I'm trying to put it in a very normal language so that we know what are the challenges and what are the solutions. Now, in Tanzania, okay. In Tanzania, we are struggling with UHC because how do we pay for the poor? Government is supposed to pay for the poor. Where will the government get the money? If you approve the bill, it means that is a legal requirement. A poor person can go to the court and claim government didn't do it and they're supposed to pay. So those are the challenges, and that's why we are coming to hybrid. And many countries of our nature, they start the way we are starting, with the formal sector to get additional resources, because government tax is there, not enough, formal sector, but also paying for the poor, so you add more resources. But there are many other innovative ways of health financing, depending on the country. Most of the ministers of finance, I would do the same. They would not like to have earmarked taxes because you are taking away from government coffers. So nowadays we have health bonds, countries like Cameroon, they have health bond. Rwanda, they have health bond, which helps government. It's a long-term commitment, and it helps to leverage resources from the private sector. And other innovative ways is not only about financing, even investment, using private sector. Government now, if you want to establish a hospital, you need to get money from Minister of Finance. But if private sector invests on the infrastructure, it means you have leveraged resources. People will get services, but the capital came from private sector. So those are the innovative ways, but government need to be very strong to regulate, to make sure that these private providers, these bonds, they really serve those who need services most. Now, I was also advised, requested briefly on other ways of, we can do this, but other things is through resource allocation. You understand, Tanzania, we are having resource allocation formula. Those are the ways, with the little money you have, how can you efficiently use that money? Yeah? How do you efficiently and effectively use the money? So you can use resource allocation formula, making sure that those regions like Rungwe, like Songwe, they get more resources compared to urban areas where they also have local owned resources. Other methods is need according to need. You assess a country, you assess a region according to their need. But these things, the way we speak, they are easy, but they are not that much easy. Because we have oh my God, I feel bad. Yeah, because we have many players. I didn't talk about partnership when I was talking about financing models. We have developed partners. All these things, sometimes they distort the system. We have duplications, yeah, wastage of resources. In other areas, I remember I did assessment of nutrition investment in Tanzania. In some areas, there is where the burden is maybe 20%, 2%, investment is 80%. So those so we need to have really, that's why I was saying, you need to work on each and every area of health financing, resource mobilization, repooling, and even purchasing. Now with the purchasing, that is the last one. Purchasing is how you pay providers, how you pay. For example, let me give you an example, which you all know, health insurance. They are paying using fee for service. Fee for service is very good for us, but that has a very negative impact to the system. When you go with a fee for service, just try. Doctor will tell you, I thank you for listening. They'll tell you, you need to do ultrasound, but I think also a chest x-ray. But these medication, these are good for pain, but even this one, but if you go with another, maybe DRG, payment method, they'll say, no, this is not necessary. Ultrasound, not important. You know, they have these, side effects. So they always accelerate the cost according to the payment method you are using. So the governments need to really work on each and every element of health financing to make sure that we have efficient and effective financing in the health sector, which will lead to UHC. Thank you so much, and apologies for rushing.
I'm going to ask if we have just 5 more minutes. Is it okay? Can we stay for 5 more minutes? I'm looking at, is it all right? 3 minutes. Mariam, thank you so much. Honestly, no apologies needed. I think it's exactly the energy that we required, and it actually brought together the entire discussion because you've raised some really essential questions in terms of how do we create a formula, right, that requires a lot of hybrid innovation to be able to meet the financing mechanism to create sustainable universal health coverage. So thank you for that. I'd like to just take at least one question from the audience so that this can be interactive. I know this is what you've done for us. Forgive me, I'm going to just go with our gentleman here in the front row for any of the panelists. Yeah.
Thank you for being just to me. My name is Omar Buguyu, Assistant Director for Non-Communicable Disease from Minister of Health. So when we talk of UHC, I know for sure this is the area that is the biggest burden on my portfolio. My question is to Mariam. I know in these modes of financing, always we are copying from what others are doing, but look at Upatu, or to most of our Tanzanians, M-Pesa, Tigo Pesa, we are not familiar with these routine or modern ways of financing or modern ways of social activities. But we've owned our own ways of creativities, and we are used to it. Mimzaramo, Kigodolo, people will contribute for it because we have our own ways of making people contributing to it. So what a kind of innovation on this financing, which is very typical African or very typical Tanzanians, but could probably assist us on financing for healthcare system. Yes.
I think, sir, can we take one more question and then we'll end there? The gentleman in, I'd like to call on a woman, sorry, forgive me, gender equity. I'm going to go with a woman here.
Thank you. My name is Anit Emmanuel from the University of Dodoma. My question goes to Dr. Grace. Dr. Grace, you have said before that you are dealing with education sectors in the provision of education on non-communicable diseases and communicable diseases. My question is, what are the efforts made in primary schools and higher learning in establishing Earth Club and Earth mentorship rather than depending on school books and curriculums that could provide a wider education in productive Earth as well as communicable and non-communicable diseases?
We'll take one more question. Gentleman in blue. Sorry. For anyone that's able to remain afterwards, we can take additional questions.
Thank you so much. I want to ask a question on population dynamics. 30% of the youth, or talk of 60 or 16 million or so, are stunted, 30%. That is population dynamics, okay? If you have 30% of your population stunted in the labor force, okay, they will not be able to achieve universal health coverage. So I think we should have to revisit population dynamics, understand dynamics, and then work on it. Because if you go to population dynamics, our pyramid population has not changed from 1961 up to 1923 in the African region, but the rest of the world has changed. So we are dying as we are dying in 1961. So please, I'll be very happy if you can support us to understand this one. So, coming on health financing, you are going to tax a stunted person with very little IQ, having 1 meal a day, okay? And you will kill this person. This is unethical. This is murder, okay? So I think in terms of opportunities, we are missing opportunities. 2,000 medical doctors on the street, CT scans in regional hospital, no one knows how to use them, billions of money, because doctors can use them, but they are on the streets. And regional hospitals are killing expectant mothers. In Morogoro, twice as much mothers died last year than 2021. And this is in the minister's speech of 2023. Regional hospitals have become a mortuary for maternal cases. So can we fix our system to give us quality care and then see how much financing we need? And please, do not kill the poor in this stunted.
Anodi, I see you, but I think we need to have the panelists respond, and maybe we have a minute at the end, beginning with, before we get to curriculum and response to NCDs, I'll just have the finance question responded to.
Thank you so much, Dr. Omari, sorry, and sir. Really, the challenge with health financing is most of the time who contribute they're not supposed or not necessarily benefit. That's the difference. Other things, part of everything, I contribute, I'm the one who is benefiting. So that's why it's very easy. People volunteer because of the benefit. But with health financing, we cross-subsidize. That is the biggest challenge. That's why government needs to intervene, because that is not really, it's it is a public good. Government intervention needs to come in. That's why we are talking about innovative financing in the current bill in Tanzania. When we started, we requested the popular mobile tax, which it was introduced. Government said no, but they agreed to introduce for another sector. We are the ones who started requesting that one. But you can just imagine the way population reacted to what was introduced. The other innovative financing which we gave forward, it was tourism. The sector was like, oh, our tourists are not going to be happy. So the challenge with health is that the beneficiary is not the one who is paying. Now, where government is now, they've decided not to go that way. They want to come with government tax for the poor. That's where they are now. We don't know if that's going to sell through because we are still waiting for the parliament. I didn't talk about community health insurance. Those are like Upatu kind. In the world, there is one which has really supported towards UHC. They can do to some extent, like our CHF, ICHF, it can do, but not universal health coverage. So those are the challenges. You need coverage, you choose what you want. You need quality, you choose what you want. Going to the poor, thank you so much. When we talk about poor, we don't talk about poor who have certain characteristics. We talk about all poor people, including stunted. By the way, the literature tells us stunted people, they earn less, I think 30% or 40% compared to their colleagues. So they are those poor people. So they're going to be covered. But it's not really a proud thing to talk about covering those people. How do we take them out of that? Because stunting, people can get out of that. How do we, and that's why this year we had Human Capital Summit to see how collectively we can work. And the challenge is, it's not only health sector with stunting, you know it very well. We have education, we have our sector, we have many other sectors. And our Minister of Finance has agreed, at least to the bank, he wrote that to make sure that multi-sectoral approach towards human capital, which includes stunting, is going to take place in Tanzania.
Thank you.
Right, no, I think the point on stunting was mentioned, but I think the issue is in terms of addressing some of these challenges around young people. I think we're now at a pivotal time in the history of Tanzania, in the sense that there are discussions now ongoing about Vision 2050 and how do you plan for this population and this large population of young people. And so for me, I think the crux of the matter is, as we look forward and we have this large number of young people, the population growth continues to increase. There's a concern about numbers, right? And therefore the quantity. And while that is valid, I think the focus should be on the quality of the population. So how do we ensure that with this population growth and with this large groundswell of young people, you talked about the pyramid, this broad-based pyramid of young people, how do we ensure that we have a quality population where we're investing in health? Primarily, we talk about health because of the context that we're in, but we know also importance of investing in education, in investing in governance, in investing in employment opportunities, in investing in skills, which come through skills both in school and out of school, but to ensure that this population of young people is efficiently equipped to contribute to the development of Tanzania. And I think that is important. And health, especially universal health coverage, and sexual and reproductive health, which is an area that is close to our heart, is critical in empowering and enabling young people to be able to achieve their full potential and to contribute to the development aspirations of the country.
Thank you all so much. Really very appreciated. I think just to summarize, we can see that this is a very multifaceted conversation, that universal health coverage, although keeps that focus on health, is actually much more about all of the social determinants of health and how we can contribute to ensuring sustainable financing through innovation, how we can ensure that we're keeping an eye on the growing population, both the aging population and the young population, ensure that education is not just in the schools, but incorporates what's happening at a community level, because as the doctor has said, there's a certain amount of innovation and empowerment that can happen by really supporting and giving agency to communities to be able to impact what's happening for greater quality universal health coverage. So thank you so much. I apologize for being a little bit late. It was a great conversation. We really welcome you for bringing us around full circle in terms of what the impact is, not just on NCDs that are coming forward, the population dynamics, but how do we bring this together in terms of innovative, sustainable financing. Thank you all so much.
Thank you so much, Dr. Oyugi.